All right, good morning, everyone. Thank you for joining us today. A little earlier than usual, but we're glad to be here. With us is our medical director, Dr. Ashley Millam, and we're going to talk all things COVID, isolation, quarantine, what the different terms mean. First, if you just want to talk a little bit about, it's been a while since we've had you on, but what are some of the new things we've learned about COVID lately?
Yeah, so I think that's a good thing to kind of start with is that there's new things all the time. And I'm sure that's incredibly, I even find it frustrating at times, but I'm sure it's especially frustrating as someone in the community, feeling like, man, it changes all the time. It seems like as soon as you learn what the rules are, the guidance is, it changes. And I'd say, yeah, that's true. And that's a really great thing. It means that as new information arises, as new studies are published that demonstrate things about this virus, demonstrate how it affects communities, how it spreads through a community, it's good that the guidance is changing. If we didn't change things as new information came to light, then we would still be practicing medicine the same way we did, in the 70s or 80s. And as we know, there's a lot of new information and how we practice medicine right now will look different than it does in 10 years from now, as it really should. So I think that that'd be one kind of thing I would just try to point out, is that as new information comes out, new and guidance changes, that's a really good thing. It means that people are paying attention to the facts that are coming to light. So with that being said, there are some newer things that have come out from the CDC over the past couple of weeks. And so one of those is that for people who have tested positive, so we would call that someone who has a confirmed case of COVID-19, they have been confirmed to be infected. It is still recommended that they remain isolated, so preventing any additional exposures, trying to limit the risk of that spreading to other people. That is still a minimum of 10 days from either symptom onset, if you are someone who has had symptoms, or 10 days from the day you got swabbed, the day you had the test obtained, if you're someone who never had symptoms. If you had symptoms, you also need to be 24 hours fever-free, and your symptoms need to be improving. They don't need to be resolved, but they need to be improving. And so those are that's a slight difference from what that was before. The other kind of big formal change that had come out about the same time was that for people who tested positive, they should not get retested to release from isolation. We know that after someone has tested positive and their infection has been confirmed, that retesting is not going to be helpful. A positive test 10 days later does not correlate with that, does not indicate that they are still infectious. By far the best way to determine when someone is no longer infectious is that timeline of 10 days from your test date if you didn't have symptoms, or 10 days from symptom onset if you did have symptoms, plus the 24 hours fever-free without medicines that would reduce your fevers, and general symptom improvement. The caveat to that would be someone who had a really severe infection. So someone who was in the hospital a long time with their particular COVID-19 illness, or if they, were in an ICU or on a ventilator or required extra oxygen, those would be more severe illnesses. And so there is some evidence that whenever someone is really sick with COVID-19, that they can stay infectious a little bit longer. So that's something that I wouldn't necessarily recommend everyone try to memorize that particular detail. That's something that your providers in the hospital, as well as our health department staff here, will be communicating about the difference in timeline for those individuals. So the other kind of big point that continues to come up, and I understand it's incredibly confusing, is that there's a difference between quarantine for people who have been exposed and isolation for people who have been infected. So the isolation is 10 days at minimum. And again, you've got a couple other pieces of the puzzle you have to consider there as well. You're not on your own with this, whether you're a close contact or someone who's been infected. We have excellent people here at our local public health agency who will be guiding you through what that timeline looks like on a case-by-case basis. But quarantine, again, is for people who have not tested positive. These are people who have potentially been exposed. And the timeline for them is 14 days from their exposure. And that is different because it's a completely different scenario. So when we think about 10 days, so a lot of times whenever you first hear that, you think, well, gosh, that doesn't make sense. It seems worse to have the infection. It's only 10 days minimum. And then if you're exposed, though, then it's 14 days. And so I would encourage you to separate these two things in your minds. They are completely different scenarios. And there is good reason for why it's different timelines. And so the 10 days is that it's someone who has the infection and how long are they infectious for? That's the reason for that timeline versus someone who has been exposed. And again, a reminder of exposure means over 15 minutes at a distance of less than 6 feet or direct contact with that person during their time that they are infectious. So if you are in that category, the health department will be reaching out to you, but the key is to stay quarantined. So to not be in contact with other people or in close proximity to other people for 14 days from your last exposure. The reason is that you could develop symptoms. You can develop the illness up to 14 days. So again, these are just completely different scenarios. And so I know that it's hard to see two different timelines, but they are different scenarios. And so there's reasons for different timelines. It's a totally different topic that you're looking at is, how long is someone infectious who has the infection, versus once I've been exposed, how long might it take for that illness to develop? So it's anywhere between 2 and 14 days, which kind of lends us to if I was exposed, if I was notified that I had that close contact, I either hugged this person during their time that they were infectious, which is also the time for infectiousness, kind of as we're talking about this, would be 2 days prior to symptom onset, or for people who didn't have symptoms that tested positive, it'd be 2 days prior to when their test was collected, so when they were swabbed. And that's important because if someone tests positive and never had symptoms and you were around them 2 weeks ago, you are not a close contact. So that kind of thinking retrospectively would be a helpful thing to think about too, as far as if you may have been exposed. So for people who have been exposed, rushing out and getting tested the day after you were exposed would not be a good idea because the incubation period, meaning the period of time it can take to go from exposure to infection, is 2 to 14 days. So getting tested 1 or 2 days after your exposure, it's very likely that you would get a false negative, even if you were going to develop the infection. So we typically recommend testing around day 7. We like to give people a window because, day 7 might fall on a Sunday where there's not great accessibility to testing, or just things can come up, may have difficulty, maybe sharing a vehicle or, which hopefully you're not while you're in quarantine, but we get that just life happens. And so we like to give people a window. So we typically say day 7 to 9, but by waiting and not testing before day 7 from your last exposure to the infected individual, that decreases the risk that you would have a negative test that would just be too early, meaning that you just haven't developed the positive test or developed the symptoms yet.
Yeah, I think that's a really great point that for people to know, because I think even me naturally, if you heard that you are exposed or your friend that you saw last weekend now is positive, it's your natural instinct to want to know, like, do I have it? But it's important to know you need to wait a little longer for that 7 to 9 day window to make sure not make sure, but to have a better chance of an accurate test. And then, either way, I think it's important to remember that you are still going to be in quarantine for those 14 days, even if you test negative. And I think that's a hard thing for people to realize and remember.
That is exactly right. That's a really good point. And so, and there's reasons for that. And so the majority of people who will develop the illness will test positive by day 7. That is not everyone. The majority is not everyone. And so you could still develop symptoms on day 13 or 14. If you did so, then you would need to get tested. And if it's positive, you would need to re-isolate. The benefit of testing on day 7 is that for individuals who are going to be, who do become infected, if you can identify that early for people who don't ever develop symptoms, you can recognize, okay, my start date for my illness was actually on day 7 rather than day 14. You save yourself a week of isolation. So we do get how we understand how incredibly intrusive isolation and quarantine are in someone's life. It saves lives to do that. It decreases the spread. So young, healthy people do get incredibly sick. You can look up people's stories online, but if we start infecting our older individuals in our community, we will see more severe illnesses, we will see more hospitalizations, we will see more people on ventilators, we will see more people dying. We do not want to see that. None of us want to see that. And so the isolation and quarantine is really disruptive in each person's life. Some people more than others, but in everyone's life. And we do understand that. But the reason that this is recommended is because it saves lives by decreasing that transmission, which ultimately tends to get to people who are more vulnerable. So please isolate or quarantine if you are recommended to do so, and do so for the recommended time. And so again, to reiterate what Ashton just said, you are not testing to get out of quarantine early. You are testing around day 7 to see if you have become infected. And if you have, then you would switch over from quarantine to isolation because you would now be a confirmed case with a positive test. If you test negative, you need to wait the rest of your 14-day period to make sure that you don't develop symptoms. Because if you release yourself early from quarantine and then you develop symptoms on day 13, you've just exposed a whole bunch of people. And maybe you've only exposed 3 people. But then if they go and they expose their families, who perhaps have some frail elderly adults in their home, it just increases exponentially as we look at the way that spreads. So we all want to be the people that if we were to test positive, well, during quarantine or after quarantine, that we would have 0 close contacts. That should be our goal.
Yes. And I mean, absolutely, that should be your goal. I know sometimes though it's hard even because of work or whatever. And so I think that's why it's so important to work with our contact tracers and be honest about who you've been around. We're not going to shame you. We're not going to do any of that. We really just want to know so that we're able to contact those people. We're able to give them the instructions. And that way, if they do become infected, they have someone there, coaching them through the whole way and they understand what needs to be done so we can kind of isolate and prevent that spread.
Absolutely.
So let's talk a little bit about businesses. I know, so we do a lot with businesses here, guidance for them. And we've seen a lot of people, though, concerned because either they, heard that a fellow coworker was positive and they don't know if they're a close contact, or people are curious why that's not really public knowledge. So could we talk a little bit about that? Why is a business not required to inform the public if an employee or customer were to test positive?
Yeah, this does come up a lot. So I'm glad you brought that up. And I bet we've probably seen some people commenting or, having questions about this. And so whenever we're in a pandemic, whenever we're dealing with an infectious disease, we are balancing patient privacy with public health. So we know that everyone's safety is important and that the health of the public is our primary concern. If we are able to identify all potential close contacts without revealing someone's identity, that person deserves to have that happen. So if there is a situation, and a lot of times there are these situations where we can talk to the person, if needed, we can talk to the employer, and we can identify who might have been a close contact. Again, that's that over 15 minutes at less than 6 feet, or direct contact during their period of infectiousness. So if someone has not been at work during their period of infectiousness, then they are not going to have any work exposures, and there would not be a reason that their business or their coworkers would need to know about that. You may want to know for curiosity, but that is not something that is putting you at risk from a health standpoint, and that is not appropriate for us to break that patient confidentiality in that type of situation, because it's not really benefiting anyone, and it could be really detrimental to someone. So then there's the cases where where they were at work while they were infectious, but they can very readily identify who they were in close contact with. So then those coworkers can be notified, but there's no reason for all 50 employees of that organization to be aware of that. We would really like there to be less stigma around this, but it's not that the stigma doesn't exist. And so again, we really want to be fair and appropriate to both sides. And then there are scenarios where we're not sure who would, after talking to the person, and then if needed, talking to the employer, we're still not able to identify who that person may have been in close contact with, that's whenever anyone who may have been in close contact with them gets notified, whether that be all employees at a workplace or whether that be all people who the public in general, if it's a place that's open to the public where they're not able to identify who may have been in that vicinity, in that close proximity with the person while they were there. That's whenever the public at large gets notified. And so that's why it's not uniform, as it shouldn't be. It's got to be case by case, because we really need to be figuring out what is best for the public. And unfortunately, curiosity doesn't weigh into that. It's really got to be, are people at risk from a health or medical standpoint? If so, then we have to do take whatever means necessary to identify and notify those people. And if there are unknowns, then they need to be notified that we're not sure. There's a lot of unknown potential exposure here. But if we're able to identify all potential close contacts of that individual, then there's really no reason to be spreading that information beyond those individuals specifically.
Yeah, thank you. We have a question here specifically asking about MU students. I know that's the top of people's mind because that's coming up in the next couple of weeks, which I can't believe summer has gone this fast. So with MU students, will their tests get reported to MU? This person has some questions about legal documents. That would be questions for the university or college, whichever one you're going to. I will say that, and maybe you know more about this, but we are working very closely with MU Health, Student Health, to figure out their contact tracing process. To my understanding, if a student gets tested at MU Student Health, then their records will be with them and they will keep a track of the number of students that were tested. But if a student were to get tested at like the MU Health drive-through or even Boone Hospital drive-through, something like that that's in the community, then we would handle that. Is that correct, Ashley?
I think that I don't think it's set in stone yet, because we want to make sure that we're providing for I know that our contact tracing team is working with all of the college and universities here, so that we can provide the contact tracing as long as we need to. But once they have their teams up and running for the organizations that are doing that, then we'll let them do that contact tracing once they're ready for that for all of the students that are there. But they'll still be in really close contact with our department here, so that the Boone County numbers will still be reflective of the students, even if, like, let's say, for example, when Mizzou's contact tracing team is doing contact tracing for their students, then our numbers would still be reflective of those students, even if we're not the ones who are personally calling each of those contacts. So that's my understanding of it. I wasn't aware of, which doesn't mean that that's not accurate, but I wasn't aware of the depending on testing location, that getting reported differently. And so that is something that may be still in discussions as far as what's the smoothest way for that. It probably will come here, but first for those other testing sites, but then whenever the paperwork identifies the person as a student, it may be that the university or the college's contact tracers and case investigators may want to take that from the beginning, depending on where they are with ramping up their particular team. So I think it'll be something that's somewhat in flux too, because as we have learned from the start of this, it's a really steep learning curve, and they've got incredible people obviously over there with their student health center, each organization with their student health center. And you've got public health professionals that are really helping guide this too. And so they are awesome. But every case has its own nuances, as we see all the time. There is no blanket statement that just works for everybody. Everyone's got kind of interesting pieces to their case that really have to be looked at. And so having done hundreds of cases can be helpful to have that experience. And so that's where we'll be working really closely with the universities and colleges and organizations to provide whatever support they need, and to make sure that we know it's important for our community to be able to have accurate numbers. And so that's where that data will all still get merged together to make sure that we're still being able to give people the kind of all-inclusive data for the community. Does that make sense?
No, I think you explained it better than I did. I was talking about contact tracing, but that is a good point about numbers. We do get that question of if students, because their permanent address might be I'll say Chicago just because when I went to Mizzou, I had a lot of friends from Chicago area. But they, some people think that it's where your permanent address is, but that's not the case. It's where you live and where you reside for that time. And there is a chance, if a student who is from another county or another state becomes positive and they decide to move, that does get transferred to the county that they're going to. So if they go back to their home county, we would transfer over to them. And that's really to just be able to follow that person, give them the accurate isolation instructions, check in on them, because since they are infectious, they are, their community is the one that needs to kind of make sure they're doing what they need to do. So yeah, we do get a lot of questions about that. So I'm glad you cleared that up. So there is also a question about close contacts. I know, we talk about within 6 feet for more than 15 minutes, but there have been some studies and some things floating around online about the virus circulating in the air. So do you know much about, if you're in a room with people for a length of time, does your risk go up, or how does that work?
That's a really great question that I don't have a straightforward answer to, but I do have an answer to. So I'll do my best with the information I have about this. And so we know that the majority of spread is through droplets. So that's where that closer proximity of being less than 6 feet, having like my computer screen ought to get wiped down after we're talking, because I don't see droplets. You probably don't see droplets, but they happen. It's gross to think about, but it's just fact. So that's why we are not close to each other, because we don't want to be sharing droplets with each other during a pandemic. Maybe ever, but especially during a pandemic, we all want to be really careful about that. And so this idea of airborne, which is, a lot of you may remember at the very beginning of this, they were talking about it being airborne spread initially. We were talking about the different masks that needed to be worn to prevent this, because of thinking it was airborne, more like tuberculosis rather than like other viruses that are droplet. And so this was a big shift whenever they realized the majority of infections were transmitted via droplets. I know there's a lot of information now about the potential airborne spread, and we know in certain settings. So I'm trying to think of some good examples that maybe aren't as extreme. So for someone who has asthma who uses a nebulizer, that's something that aerosolizes particles. So what would be droplets can then very easily become airborne whenever you're using a nebulizer. So there's several examples like that, but that's probably the most kind of common or kind of outside the hospital scenario. And so that is something that there would definitely be risk just being in the room with someone if you weren't wearing the appropriate mask and eye protection and all of that. There is, as probably most people are aware, because it's been pretty well publicized, there was a group of scientists and providers and doctors who submitted a letter requesting, I believe it was the World Health Organization, to relook at potential airborne spread. So I think there's more studies going into it now. My understanding right now is that there is potential airborne spread, but that is probably very rare. And that is not a fact. So I hope I'm presenting it very clearly that this is being investigated more. But the data we have now, it looks like far and away the majority of spread is through droplets. And so knowing that there's this potential airborne spread, this is one of the reasons that we don't want people crowded into a closed off room. So if you are getting together with people outside of your immediate household, being outside, keeping 6 feet apart, wearing masks, that helps with droplets. But that also, if it's airborne, you can imagine being in a closed in space. And again, I'm saying that not because this is fully being identified as an airborne virus. I hope that is clear. It's still considered droplet spread, but they are looking into potential airborne spread. And so us being as smart as we can be about this in light of that is a good idea. So if you can be outside, if you can maintain your distance, then even if some of those droplets get into the air, the virus gets into the air, it is much less likely for a significant amount to get into your body and then you to get infected. So that is very much a gray zone. in my answer, but I hope it's clear that it's a gray zone at large. So it's being looked at, but they're usually the World Health Organization is pretty conservative, which is why at the beginning of the pandemic, it was considered, and the CDC also considered it potential airborne transmission at the beginning of the pandemic. I think this was even in early March. I should be able to tell you the day that it switched over to droplet, but it was pretty early in the pandemic. But it really, they considered it airborne until they found enough evidence that it was really droplet. And so it's good that they're looking, again, like we talked about at the beginning of this, there's new information all the time that has to be examined, and guidance has to change whenever new things come to light. And so right now, it is far and away most likely droplet. But never hurts to be safe and think about maintaining extra space, being outside, having good ventilation if you're inside and it's appropriate to open windows. That can be helpful too.
So it sounds like you're really talking about a layered defense with, masks, social distancing, no matter if you're inside or outside.
Absolutely.
Yeah. So we're kind of running short on time here today, but you were talking throughout this whole thing about CDC guidance specifically. And we do get that question a lot of where do we get our information and our sources. So can you talk a little bit about why we use the certain guidance that we do?
Yeah, absolutely. So we follow CDC guidance as a local public health agency. And I do have to say, so I think this would be a good example that I'm going to give some kudos to the CDC that I haven't always done on our Facebook Lives, because I speak really genuinely about this is my perspective. It is not perfect. I don't know all the information. I hope that comes across very clearly, but I give you the information that I have at this point in time. And I would say that even up to early June, I was really questioning the benefit of masks. CDC came out really early and recommended mask wearing in public. And I had a hard time getting on board with that because I'm a physician. I want to see evidence. I'm trained that I need to see evidence. I need to go, I can't go off of Gestalt. I can't go off of instincts or gut. You have to see, like, prove it to me for me to recommend it to patients and to my community. And so it has been proven now. There's a ton of data. There's this turning point in mid to late June. A ton of articles have been published on the benefits of widespread mask wearing. But I have to say that gave me a lot of faith in the CDC, because I thought, wow, I was like 6 weeks behind getting on board with that recommendation, which is good to very, very humbling to realize that I was really delayed in that. And so with a novel virus, with a new virus, you can't just wait on months of data to be published, because otherwise you will be 6 weeks behind in your recommendations, which I can speak from now with personal experience to that. And so you really have to look at expert opinion too. And we really do want to be looking at non-biased organizations, which there's always an argument for every organization to have potential biases. But if we look at, is this organization really benefiting from, like, they're not convincing us to buy something. And so I think that is really helpful whenever we think about looking at what I would consider non-biased information and really trying to get expert opinion. There's people in these positions because of their background, their knowledge base, their experiences. And then you also, I think it's great to look at different organizations. And so you look at World Health Organization and CDC and different academic institutions. I mean, wow, we've got Johns Hopkins University is doing a great job of putting out information. I think that's where a lot of the dashboards come from, even Harvard's public health school, our public health school. There's all sorts of places that you can look for non-biased information. These places are not trying to sell you something. They are really taking the information they have, the lens they're looking through, their perspective, and just trying to share it as broadly as possible. So I think it's great to use more than one organization, but you really want to use organizations without a hidden agenda who would be looking at this specifically for the benefit of the public.
Yeah, thank you. And we do have a Facebook Live coming up on Friday talking about misinformation and how to kind of spot it online. And so we have some local journalists and health communicators that will join us to help share some tips. Before we wrap up, we do have some teachers that are asking some questions. School's coming up, it's on their minds. And they want to know, in a classroom setting where obviously you probably can't be outside, what what is considered a close contact if you're trying to distance and you're wearing masks? Like, let's say that they're doing all of the protective measures they can do. What's the risk there?
Yes, it's pretty low risk if you can keep students and you can maintain 6 feet, which I know that even saying that I'm like, oh, I know that's hard. I can imagine. I cannot say that I know that's hard. I can imagine how hard that is, especially depending on the age of your students, to maintain that 6 feet of distance. But maintaining 6 feet of distance between the students, having them kind of ensuring appropriate mask wearing, that is going to decrease your risk of having that close contact, that higher level exposure a ton. As the teacher, I'm sure there's going to be times where you cannot maintain your 6 feet of distance for a variety of reasons, because you want your students to learn things, and sometimes being closer to point things out or demonstrate or show something, or sometimes for maybe non-educational, maybe just trying to keep students safe, and that you may need to get less than 6 feet. But if you can keep that more brief, if you can keep that to be a few moments here and there, that's going to be a lot different than over 15 minutes. And so it does tremendously decrease your risk if you're able to maintain that distance and maintain that mask wearing safely. I also can imagine that looks extremely different for an early elementary school teacher and a junior high or high school teacher. And I'm not saying any of it's easy by any means, but I think that it maybe is potentially more feasible in certain situations. And if you do have, if we think about the smaller stable groups, that if you're in a situation where you can't have everyone be 6 feet apart, if you can have smaller groups to where, okay, well, if one child develops the infection, then it's this small group that they were sitting in that would have been potential close contacts versus anyone in the classroom. On nice days, if it's allowed to open windows and you don't have students who have bad allergies, I'm sure there's a lot of things you have to think about with that. So I may be speaking out of turn. I'm sure the teachers are aware if they can or cannot open windows. I mean, that would definitely allow for ventilation when it's appropriate from a climate standpoint and for other health reasons standpoint. So those would be my recommendations, is that it definitely decreases risk dramatically. Again, it is, even though we're recognizing they're looking at how potential, or how likely is it that there could be airborne spread, we know that far and away, the majority of infections are spread via droplets. And so masks, 6 feet distancing, the combination of the two, those are incredibly helpful at decreasing your risk.
And I will say, our teams are working very closely with all the school districts in the county to figure out guidelines. It's a stressful situation for everybody. The guidance is changing every week, and the status of COVID in Boone County changes every week. So we're really, going back and redrafting and changing certain things and making sure that all the plans are most appropriate for each district and each building and all of that, to make sure everyone's safe. So hopefully, those watching who are concerned will have some answers soon from their districts, but we are working closely with them and are trying to get that out as soon as possible. All right. Well, thank you so much for joining us today. Like I said, we will be back for Facebook Live on Friday, talking about misinformation related to COVID-19. And in the meantime, if you have any other questions, you can message us or email us at coronavirus@como.gov.
Thank you.
Thank you.